Right, we'll get started. So hello everybody and welcome to our latest 12-minute take-home webinars from VetCT. It's great to see a lot of you coming through and still some more people joining as we get started. Just as a reminder, VetCT, we recently launched our new app and teleconsulting service. We would love for you all to give it a try. So through the app, vets get instant access to a team of friendly specialists offering support and advice on those tricky cases. You can choose to communicate with the team or specialists via instant callback, text chat, book an appointment at a time that suits you, or ask for a written report. We've now made it even easier for you to interact with the team. It's almost like having a specialist on speed dial. Simply ring through via the app and our team will create the case and get in touch with the specialist, especially during the busy summer months. You will learn on each case, of course, and anyone in the UK also gets the added benefit of real-time CPD on those. If you do want to give it a try, just download the app from the App Store or Google Play. You can scan the QR code that you can see on the screen at the moment. It will take you directly there. This is beneficial for both employed and local vets alike, and we'll be happy to talk more. You can see my email address on the screen if you want to discuss it in more detail. But let's move on to today's 12-minute webinar. As a quick reminder, the session itself is being recorded, and there will be an opportunity, to ask questions at the end. So please do add any questions into the Q&A section of the webinar. We'll answer as many as we can in the time and follow up with any others that we can't get through after the webinar. So first of all, let me introduce you to our oncology team. Dr. Sofia Carvalho is from the team will be presenting today's talk. So you can see everyone else on the screen there as well, the rest of her team for you. So I'm going to introduce you now to Dr. Sofia Carvalho with today's session. There is a mass in the heart. Can I do anything? So Sofia, I'm going to pass over to you now to take us through the session.
Thank you, David. That's great. So yes, we are here today to talk about this interesting subject. There is a mass in the heart. Can we do anything when we come across this diagnosis? And let's see what are some of the options that we have for this type of neoplasia. So just a quick overview about cardiac tumors in veterinary medicine. So primary cardiac tumors, the most common one is the hemangiosarcoma that accounts for between 40 to up to 70% of all the cardiac primary tumors in dogs. This is followed by aortic body tumors, which usually sit in the heart base location, and they can account for up to 30% of the cases, followed by lymphoma and ectopic thyroid carcinomas, which happen in approximately the same percentage. And this is followed by every other primary tumor that may be able to occur in the heart, and also some cases of metastatic cardiac neoplasia. In cats, cardiac tumors are quite unusual. In one of the searches, they saw that they account for less than 0.02% of all tumors in cats, and lymphoma will be the most common primary cardiac neoplasia in this species. So the differential diagnosis of a cardiac tumor is often based on a combination of factors, including the clinical history of our patients and also the physical examination and radiographic findings. So if we start thinking about patient age, patient breed, location of the tumor, it's quite important as well. We know hemangiosarcomas like to sit in the right auricle or in the right atrium. We know that chemotherapy, aortic body tumors, they like to sit in the heart base location, as we said. So these are the things that we use to try to make a differential diagnosis list. And then the diagnosis will require imaging. In most of the cases, we'll use echocardiography, what is more easily available, and that's really useful information. And this is followed by advanced diagnostic imaging such as CT scan and MRI when it's possible. But the truth is, in the majority of the cases, an antemortem cytological or histological confirmation of the neoplasia is not obtained, and we go with a presumptive diagnosis. So the majority of these patients that are diagnosed with a heart mass will be treated based on the anatomical location of the mass due to the risks of obtaining a definitive diagnosis. And as I said, if we think about right atrium or right auricle, we start thinking about hemangiosarcoma. If we are thinking about chemotherapy, we start thinking about the heart base. So the initial treatment of these patients will be directly to improving their cardiac output, stabilizing their hemodynamic function, correct any arrhythmias that they may be experiencing, and in some cases, more severe cases, congestive heart failure. Although it's important to remember that all of these measures, which usually involve the help of a cardiologist or emergency care criticalist, will have some limited efficacy unless we can do something to manage the primary tumor. So it's really important to know what options do we have to target this primary tumor. Sometimes in the face of not having a definitive diagnosis and having to work with a presumptive diagnosis, putting all the pieces of information of the case together. So some of the treatment options for cardiac tumors can include surgical excision, they can include performing a pericardiectomy, they can include administration of chemotherapy drugs with cytotoxic treatment, but also drugs such as tyrosine kinase inhibitors. And in some cases, radiation therapy treatment may play a role as well if this is available in our region. As of surgery, so the surgical resection of a primary cardiac mass in most cases is limited to tumors arising from the right auricle. And most of these tumors, as we said, they will be the hemangiosarcomas. Not all of them will be hemangiosarcomas, because we know that from studies that we cannot trust 100% in the location. There's still a high percentage of cases that will be in the right auricle and not be hemangiosarcoma, and vice versa. But we should also remember that although these in case of hemangiosarcoma, although they can be removed in many cases, this resection, the surgical resection, should be considered palliative due to the high metastatic nature associated with hemangiosarcomas in dogs. Performing other types of surgery, such as some pericardiectomies, it's really important, and it has been shown that doing pericardiectomy for dogs diagnosed with heart-based masses will improve their survival time, especially in cases of aortic body tumors and mesotheliomas, and this is regardless or not of whether you have a pericardial effusion presence of time or diagnosis or not. So let's just see some types of chemotherapy. So we use chemotherapy a lot for cases of hemangiosarcoma. We know that doxorubicin-based chemotherapy protocols are the most commonly used, and they can be used either as a primary therapy in the presence of gross disease where you're not going to perform surgery, either because it's not operable or because you have a patient with advanced stage disease, or you can use chemotherapy adjuvantly after the surgery, okay? So we tend to use doxorubicin-based protocols very much as we use in cases of splenic hemangiosarcoma, for example, and we can use this doxorubicin either as a single agent, where you do doxorubicin every 2 to 3 weeks, or you can combine the doxorubicin with another drug. You can combine it with cyclophosphamide and do an AC protocol, where you administer each drug approximately every 10 days. Or you can intensify even further the protocol, doing a VAC protocol, where you're going to combine the doxorubicin with cyclophosphamide, and you've increased in administering each drug every 7 days. So that's a more intense protocol where you have a multi-agent therapy approach. This sometimes it's too much for certain people, certain families, or sometimes doxorubicin won't really suit the patient due to a toxicity associated with the treatment. So there are other options out there as well. Metronomic chemotherapy, it's quite a popular option, and we know that it can be, there is some efficacy behind it, especially in cases of hemangiosarcoma in the spleen. So that's something to consider. And nowadays we know that there are some herbal therapies that are out there as well. So if you have a patient that doesn't want to go through the conventional therapy, you can start thinking about things like Yunnan Bayao, which is like a ginseng extract that can help with bleeding, or you can think about mushroom extract components such as the Coriolis versicolor we can see in this pretty picture of the mushroom here, and that would be for people that don't want to go the conventional route. What's the prognosis? So the prognosis, we know that if we do surgery for cardiac hemangiosarcoma, it can range from just a couple of weeks to 4 months time, which, you know, it's poor. The prognosis is generally poor for hemangiosarcoma in dogs anyway, either in the spleen and in the specific case in the heart. But we know that adding doxorubicin-based chemotherapy treatment after surgery does improve survival time. So it's definitely indicated. And as I said, we can use it in the face of gross disease as well. And we know that doxorubicin does work in the face of gross disease and in cases with stage 3 disease, for example. So median survival time with surgery and doxorubicin-based protocol, it's almost 6 months. What about heart-based tumors? So heart-based tumors can be quite rewarding to treat as well. There's been a study where they evaluated treatment of canine heart-based tumors with docernate phosphate, with Palladia, and they had overall median survival time of almost 3 years of 823 days. That survival time, although not statistically significantly different, was better for dogs that had no metastatic disease associated with their heart-based tumors versus if they had metastatic disease, which of course makes sense. So about 796 days versus 500-ish. And most importantly, the treatment with Palladia helped the dogs improving that clinical symptomatology associated with diagnosis of heart-based tumor in up to 90% of the cases. And in 81% of these, there was a complete resolution of clinical signs after starting the docernate. So certainly it's a very attractive treatment option for dogs with a heart-based tumor. Furthermore, as we said before, these dogs may benefit from performing a pericardiectomy, and it has been shown that performing the pericardiectomy, again, regardless of whether we have pericardial effusion or not associated with tumor, does improve median survival time, where we have median survival times ranging from 600 to 730 days if we perform pericardiectomy versus only 42 days to 129 days when the pericardiectomy is not performed. In cats, it's quite a rare disease and we don't have much information in the literature. Lymphoma is definitely the most common cardiac tumor. And we have this study, including only 7 cats, where the median survival time was only about 9 days. But there's only so much we can say about this because we are literally looking at 7 cats with pericardial lymphoma, which is nothing. Important to say that 1 cat in this study, which were treated with a CHOP-based protocol, did have a great survival time of 750 days, which is really, really good. So we know that treating lymphoma, always chemotherapy is indicated. So we definitely recommend ideally a multi-agent protocol such as CHOP or a COP protocol, and that would be definitely recommended. So just put a couple of cases together just to go through you and help us thinking about what are the options out there. So this is little Mel. Mel was a 10-year-old female neutral Labrador. She presented one day to our hospital as an emergency after suffering an episode of sudden collapse while on a walk. She had no other previous medical history. She'd been completely healthy with no concerns up to that day. And she was fully up to date with our vaccines and deworming. So on physical examination, she was quite poorly. She was collapsed. She was very tachycardic, heart rate of 180. She had muffled heart sounds and poor pulses. So she was quite in a shock. She also had a moderate abdominal distension, and otherwise no significant abnormalities could be identified in a physical examination. No lumps, no bumps, and really good body condition score. So she was stabilized by our emergency criticalist team, and her ECG revealed a sinus tachycardia initially with some occasional VPCs. And then after stabilization, echocardiography was performed, which revealed a large amount of pericardial effusion with evidence of tamponade. And then we could also appreciate that she had a right auricular mass, as we can see in this short video. So in the presence of a heart-based mass, we went on to perform further investigations. She had some blood work performed, which revealed moderate to marked regenerative anemia. She also had a mild to moderate thrombocytopenia and no other really significant abnormalities. So when we start thinking about differential diagnosis for Mel, we started thinking about, first of all, the tumor location, also the blood work results, her breed, her age, all of that. And mainly due to the location, hemangiosarcoma, they were the 3 main differential diagnoses for her. And this would be followed by all the other cardiac tumors that we spoke about. So in the face of diagnosis of a heart-based mass, we went on performing staging with a CT scan, and unfortunately we found this large splenic mass, which has this cavitated appearance and also some evidence of prior or active bleeding, some mild evidence of peritoneal fluid. And at the time we discussed with the owner what would be our treatment options. We had quite committed owners here, and so we discussed that we could try surgery. So she was a candidate for surgery after discussion with a soft tissue team, and she underwent to have a splenectomy and resection of a right atrial mass, which was great. This was followed by adjuvant chemotherapy with a VAC protocol. And we combined as well, we use a little bit of integrative oncology here, and we used the urban medication Yunnan by Ao. And she did quite well. So she received the treatment, she received the 6 cycles of the protocol, but unfortunately, after 5 months from initial diagnosis, at the time of her staging, after finishing the VAC protocol, her disease progressed. And at the time, she had evidence of pulmonary nodules, several pulmonary nodules consistent with metastatic pulmonary disease. And so at the time, we discussed other anti-cancer therapies that Mel underwent to receive, such as metronomic chemotherapy, dacarbazine. And Mel was with us for about 6.5 months with a really good quality of life. She was likely to tolerate all the treatments quite well. So obviously it's a poor prognosis. It is not lots of time, but we were facing and dealing with a patient with advanced stage disease with an hemangiosarcoma. So it is a good result to have, especially because in her case, she was likely to have a really good quality of life. Just quickly, just another case. This is Alex, a 7-year-old male-neuter dog that presented to his private practice with a non-specific 2 to 3 months history of inaptitude, weight loss, and lethargy. He was diagnosed with right-sided congestive heart failure and a heart-based mass at his practice based on echocardiography. He started receiving furosemide and pimobendan, and he was presented to us for discussion of treatment options for his heart-based mass. On physical examination, he was quite bright, he was a little bit tachycardic, we could hear some kind of arrhythmia, and we could hear a grade 5 out of 6 systolic heart murmur, most audible on the right hemithorax. He had evidence of jugular venous distension. He also had a marked abdominal distension with a fluid wave, but he also has a body condition score of 3 out of 9, suggesting there was something going on for a while, possibly. On echocardiography, we identified and confirmed the presence of a large heart-based mass. He had the right arterial enlargement, but no evidence of pericardial effusion. His blood work was quite unremarkable. And again, in this case, we went on performing staging to evaluate any presence of metastatic disease. We didn't do a CT scan here, mainly due to financial concerns. So we went with the most traditional staging approach with 3 view chest radiographs, which show no evidence of pulmonary metastasis. We also performed an abdominal ultrasound, which showed a large volume of ascites and some splenic and hepatic nodules. Which subsequently sampled with fine needle aspirates, and cytology revealed no evidence of malignancy. It's quite common for us to diagnose lots of splenic and hepatic nodules during staging of neoplasia in these age dogs. So for Alex, a little bit different, the differential diagnosis list, because we are thinking about the heart-based, we are thinking about the breed as well. These brachycephalic dogs, they tend to be most commonly diagnosed with heart-based tumors. Again, it's a presumptive diagnosis. We didn't perform any cytology or any histology, so obviously it's always going to be a presumptive diagnosis. But for him, putting all the pieces together, chemodectoma will be the 3 main differential diagnoses, followed by all the other most common primary cardiac tumors. In his case, we did talk about performing a pericardiectomy, but his family was not really interested to put him through invasive procedures, and there was also the financial constraint in the family. So we discussed about doing Palladia, which should be attractive from that point of view, not invasive, not many visits to the vet, something that they could do at home, and they were quite happy with that. So initially, it was most importantly managed by our cardiology team to manage the right-sided cardiac failure, and there was a list of cardiac medications that I won't go through. But from the oncology point of view, he was receiving treatment with Palladia on a 3 times a week schedule, Monday, Wednesday, Friday, and he tolerated that really well and still alive and doing really well with us 14 months after diagnosis. He comes regularly, approximately every 2 to 3 months, to have an echocardio and to check that things are more or less stable, and he's doing great. So this is what I wanted to share with you. So if we go back to the initial question of this seminar, there's a mass in the heart, can you do anything? Yes, the answer is yes. There are many things that we can do. It's difficult because, as I said, majority of the dogs are treated based on a presumptive diagnosis, and we need to think about all the factors and try to understand like what is the most likely diagnosis, and then try to make a plan for the patient. But there are things that we can do, and in some cases, depending on specific scenarios, long-term outcomes can be achieved, especially if we are dealing with chemotherapy, for example. So important, first stabilize your patient and get the cardiologist, get the criticalist involved if you can, and after that explore what are some of the oncological treatment options available out there. And that's it. I'm happy to answer any questions now. Let's have a look. We have a few questions here. Let's see. This first one, when using Palladia, standard dose and schedule. So we do it 3 times a week. We do it usually Monday, Wednesday, and Friday. We tend to start with a dose of about 2.75 milligrams per kilo. And they tend to tolerate it really well. The main adverse effect when using Palladia is development of GI toxicity, mostly with the diarrhea. This is something that in some cases can be temporary. So you start the Palladia 1 or 2 weeks later, they started developing diarrhea, then you can do what's called a drug holiday, stop for a week, try again, and they may resolve. Or in some cases, you can go even lower and you can, for example, try a lower dose to 2.5 mg per kilo approximately. So, but that's the typical schedule. So 2.75 mg per kilo, Monday, Wednesday, Friday. That's what I tend to start with. So we have another question here, metronomic chemotherapy. People talk about it, but I'm a bit unsure what does it really mean in terms of drugs and doses. Okay, so metronomic chemotherapy, usually the typical one is a combination of cyclophosphamide at metronomic doses. Metronomic doses are tiny doses when you compare to the doses that are, for example, part of a CHOP protocol or an AC protocol, for example. So the metronomic dose of cyclophosphamide would be something around 12.5 milligrams per meter square, depending on the paper that you read. And you do that on a once a day basis, okay? And then you combine that with a non-steroidal anti-inflammatory, COX-2 specific, something like firocoxib, for example, or robenacoxib, something COX-6 specific. We do have some papers talking about metronomic chemotherapy in cases of splenic hemangiosarcoma, where they use a little bit higher doses. So that's something to think about. Hope that answered the question. Another one here. If there is pericardial effusion associated with the tumor, is there anything other than simple cytology of the fluid you can request to get more information about possible tumor type? Yes, so you can test for troponin I, and depending on the level of the troponin, that can help you getting the diagnosis. So for example, don't remember what's the value now of the troponin now, but there is a couple of papers with it, and depending on the value, if it's high enough, it makes the diagnosis more likely of hemangiosarcoma and more likely even of a cardiac hemangiosarcoma. So that's an excellent question because it's something easy to do and not very invasive. Thank you for that. Sharat, hi, could you explain which tumors cause hypercalcemia? So cardiac tumors are not the most common tumors to cause hypercalcemia. Usually when you think about hypercalcemia, the first thing we think about is lymphoma or lymphoid tumors. We think about multiple myeloma, we think about anal sac tumors, and there is an extensive list of tumors that can cause hypercalcemia. So the ones in the heart specifically, we don't usually see associated with hypercalcemia. That's not to say that it cannot happen. That's not true. It can happen. And lymphoma, of course, it's the third most common cardiac tumor. So it can happen, but it's not the most common thing that we see when we diagnose a dog or a cat with a cardiac tumor. And then hypercalcemia in cats associated with neoplasia is much less common than in dogs. We have another question here. Is CT helpful in these cases? Yes, CT can be quite helpful, perhaps to try to guess. I mean, it's not really very scientific to guess anything, but sometimes to help, how does the tumor look like? Is it like cavitated? Is it very attached? Is it more pedunculated? Things like that can try to to help us predicting what type of tumor we are, but CT is really helpful at staging the disease, because I mean, you know, CT is great for example, things like pulmonary metastases. When we think about hemangiosarcoma, many times we see like small nodules as well, like intramuscular or subcutaneous nodules. So the CT is good at that. So CT, yeah, it's a great diagnostic tool. And if your patient needs to be stable as well, I guess, because not all the patients, like for example, Mel was not greatly stable when she presented, so we had to wait. But yes, CT is a great advanced diagnostic imaging in these cases. Another question, is CT helpful to decide to decision-making regarding surgical resection? Yes, as we just said, yes, it's very good, and that may help us. The surgeons would really like to have a CT to try to help deciding, and sometimes it's good to combine teams, it's good to combine diagnostic techniques. So yes, I would definitely answer yes to the question. Lily, hi, are there cardiac neoplasias that exfoliate with FNA? Yes. So, I mean, for example, lymphoma, we always think about lymphoma as one of these tumors that exfoliates really well. So lymphoma will exfoliate really well. Things like hemangiosarcoma, they don't tend to exfoliate really well, mostly because they like to bleed. So many times they presented with hemorrhagic pericardial effusion. And I think sensitivity of cytology, there is a paper where you have sensitivity of cytology in these specific cases, and it's really low. It was something like 10 or 8%. It was really low. So the hemangiosarcoma, the most common one that happens in about 2/3 of the patients, does not tend to exfoliate really well, but it might, and it may be lucky your case that it exfoliated. It's not impossible. Heart-based tumors or chemotherapy don't tend to exfoliate very well as well. You can have things like mesothelioma as well. Sometimes you are lucky enough that mesothelioma cells will look quite angry, and you may be able to diagnose them based on fine needle aspirates and cytology as well. And we have one last question here. Sharat, hello again. If the doxorubicin or any other chemotherapy drug has gone extravascular, what to do and medication can you give? Oh, that's quite a complicated one. So definitely, I mean, there is a protocol. If you want to, you can contact me by email, and maybe I can send you some more information regarding that. But that's really going to depend which drug was extravasated. If it's doxorubicin, you have some antidotes for doxorubicin. If it's vincristine, there is another drug that, like hyaluronidase, that you should administer. Depending on the drug as well, it could be that we are recommending to do ice packs versus heat packs. And there's all sorts of protocols for extravascular chemotherapy incidentally. So maybe just send me an email. And we can chat more about that, and maybe I can send you some more information, because that's a more complex question that I need to give you more information than just a quick chat. I hope that's okay. Let's see. Oh, you're welcome, Lily. Thank you for listening. That's really great, and thank you for the questions, everyone. Thank you, Sharon. Thank you all for being here. Hope everyone has a great day.
Thanks, Sophia. Thank you, everyone, for attending. And thanks for all the questions. Lots of great questions there. I hope everyone found that interesting. Do keep an eye out for our future sessions. We've got another one running next Wednesday. That's with Dr. David Gould on Wednesday, 25th of August at 12:30 UK time. It's an ophthalmology session. So you can register ahead for that. The recording for this webinar will be available on our website and YouTube shortly. Finally, don't forget to download the app or try the service throughout. You can try it through our desktop version as well to be able to speak to Sophia and our other friendly team of specialists. We'll leave the screen up for a second so you can scan the QR code. I've noticed a few of you have actually downloaded the app while we've been speaking, so we will be getting in touch with you shortly about that. But otherwise, if you have any questions, you can reach out to myself or Sophia directly, and have a good day. We'll see you next time.